Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Boehringer Ingelheim Pharmaceuticals, Inc.
My name is Jose Rubio. I am assistant professor of psychiatry at the Zucker School of Medicine, and I do research in schizophrenia, but also I have a practice in our hospital, which is a large facility that takes care of a lot of people that have severe mental illness. As a clinician, I think that it's very important that people walk out of the session with clinically actionable things that they can do and implement in their practice. Otherwise, it's not so helpful. Okay, so I'll try to make it actionable and I'll try to make it concrete so that you can go back to your clinic and do things differently. Thanks to this presentation. So schizophrenia is a chronic disease. It's a chronic syndrome, rather. It affects about 1% of the population for most of our lives. And there are three elements that are core to this syndrome. One of those elements is obviously psychosis. So those are positive symptoms. Those are delusions, hallucinations, and that's considered to be one of the core symptom domains of schizophrenia. And not only schizophrenia, but other symptoms as well, like bipolar disorder, etc. There's also negative symptoms. So negative symptoms is another symptom domain, which is core to schizophrenia. And that is characterized by the 5 A's of affective flattening, alogia, anhedonia, amotivation, and asociality. And the third leg of this tripod, if you will, is cognition. So cognition is the other symptom domain that's core to schizophrenia. And that is characterized by a number of different functions that we know are not okay in patients with schizophrenia. So that's what we're going to be talking about. And I'll give you more detail about that. But what do we mean by cognition? At large cognition, what it means is how is the brain processing information? But then there are different types of things that the brain does with information. I think that this acronym is very helpful to put in our heads what are the different cognitive functions that we are referring to. So one cognitive function that we are referring to is the speed of processing, which is quite self-intuitive, is how is the brain taking in information and doing something with it. And then there's the memory, which is essentially the ability to retain information for later use. There's attention, which is the ability to stay focused on one source of stimuli and ignore other irrelevant stimuli. There's reasoning, which is the ability to reach conclusions based on a logical processing of information. And then there is tact social skills in this SMART acronym, which refers to how are patients able to use nonverbal cues, to attribute mental states to other people, etc. And this is critical so that they can develop, so that we can all develop social relationships. These are five cognitive domains in schizophrenia. And as you can see here, it's looking into some of the symptoms within those 5 domains. But when you're looking at a wide range of cognitive functions, it's very clear that unlike in other mental disorders, in schizophrenia, they are affected across the board. So here you can compare the cognitive impairments that you observe in schizophrenia versus in bipolar disorder and MDD, ADHD, etc. And what you can see is that there are all of these domains that are affected in schizophrenia when they are not affected in other disorders. So clearly, schizophrenia is a cognitive disorder, and however, cognition or cognitive deficits rather don't present in isolation. So typically, and I'm sure that you have experienced this in the clinic, it's very often unclear whether what you're observing are cognitive symptoms or negative symptoms. So we're going to clarify a little bit what the difference is and what are negative symptoms. Negative symptoms can be seen as a link with cognitive symptoms, but they are different phenomena. They are characterized, as I was saying earlier, by affective flattening, alogia, anhedonia, volition, and asociality, and they can be clustered. This type of negative symptoms can be clustered into 2. One that's more expressive which would be affective flattening and allogia, and another one that's more related to motivation. So that would be anhedonia, avolition, and asociality. So just to make sure that we understand what this means, affective flattening is reduced expression of emotions. So that is something that's very observable in patients that have schizophrenia that may not have the same emotional expressivity. I'm sorry. There's allogia, which is poverty of speech, right? So the verbal output will be decreased. Then there's anhedonia, which is the reduced experience of emotions. So it's not necessarily that they want less, but also is that they experience less. And then there's abolition, which is that they want less, right? So there's not so much interest in looking for experiences or in looking for novelty. And the last one is asociality, which essentially means the lack of interest in interacting with other people, which unfortunately is very common in schizophrenia. So these are negative symptoms. This is different from the cognitive domains that I was talking about, and they express differently in the clinic. So it's important when you're seeing patients to draw the distinction between the two, between the cognitive symptoms I was referring to and the negative symptoms I was referring to. However, the negative symptoms can be just because of the nature of the illness, right? So in schizophrenia, there are deficits with dopaminergic function in the brain, and we know that this dopaminergic function in the brain is essential for reward processing. So they may have problems that are related to reward processing and other negative symptoms just because of the biology of the illness. But in addition, we are typically doing things, or there are other things happening that may look like negative symptoms. For instance, antipsychotics may make it more difficult to express emotion because patients may be more stiff, and that may translate into flattening of expressing emotions. There could be comorbid depression, so there's not necessarily difficulty with motivation. It's just that the person is depressed, you treat the depression, and that goes away. So these are examples of negative symptoms that may occur as well in schizophrenia. But I think that this is one of the most important slides when it comes to the relationship between negative symptoms and cognitive symptoms, is that they feed on each other. So that's why they are typically present when patients have high burden of cognitive symptoms. They tend to have high burden of negative symptoms, even if they have to be described separately. So what happens is that if you have poor motivation, then you're not going to engage in cognitive tasks, and that's going to show like having poor cognitive function. But then at the same time, if you have poor cognitive function, you're going to be unable to connect the steps and make the connection between behavior and the reward. So then you're going to not have that motivation. So it like fits into each other, and that's why the two go usually hand by hand. What is the impact of cognitive function in patients' lives? It's known that both cognition and negative symptoms are actually much more relevant to function than psychosis. Psychosis we can treat. It actually can be very dangerous, but it's not really what drives disability. What drives disability are negative symptoms and cognition, which are the most difficult to treat. And it's not surprising. If there's poor cognitive function, that's going to result in difficulties getting a job. That's going to result in people being socially isolated, not being able to do in school. You're not going to be able to take care of your primary care needs, etc. So it's unsurprising that cognition is really what's driving the disability in patients that have schizophrenia. And here I am showing you a slide in which you can see the relationship between the cognitive impairment and the dysfunction and functional impairment. And what you can see is that across the different cognitive domains, there's a high correlation that you can see is very significant between the impairment in cognition and the impairment in function. So they go hand in hand, and it seems to be across the board. It's not one cognitive function that's driving the impairment, but it's across the board. And the other thing is that patients tend to have impairments across the board. It's not one cognitive impairment that will be going awry. I think that these are very interesting data here. What you can see are what are the factors that make it difficult for patients that have early phase psychosis to go back to work and school. So this is really what patients care most about. Can I go back, and can I go back to school? Can I graduate? Can I get a job? And really, when you look at all of the contributions to the difficulty to go back to school or work, most of the variance is explained by neurocognition. So here it was working memory, which is one of the cognitive domains attention and early perceptual processing, and verbal memory and processing speed. These are three cognitive domains, and just those three cognitive domains, they explain 52% of the variance in going back to work or school. So it's clearly a critical outcome that is going, if we were able to manage it properly, or have, even if it's a little bit of an impact, it would translate in better outcomes, in things that patients really care about. Here are more data about what is the relationship between cognition and function. So if you're looking at function from the perspective of functioning in the community, or from the perspective, which you can see on the left, or from the perspective of social skills, which you can see on the right. Here, what is that the association, being a positive association, being a positive number here on this forest plot, what you can see is that is very consistent. I think that the learning point from this slide is that cognition is pervasive across domains, and all domains have an impact on functioning on the community and in social skills. Again, this goes to say that treating cognition is very important so that patients can recover. And one problem is that this is something that is present at the very beginning, since patients are diagnosed, and does not get better over time. So here you can see data from a cohort of early phase patients for whom cognitive testing was done. And here you can see what are the deviations from healthy controls in terms of performance across different domains of cognition. So language, memory, attention, executive function, etc. And what you can see is that their C-scores, which essentially is a measure of distribution of the scores compared to healthies, is about an average of 1.3, which means that it's a very large effect size. It's a very large impairment that's already present when patients are diagnosed, and it does not get better. So these are data from a larger cohort of early phase patients that were followed up for up to 20 years. And here what they measured was the cognitive functioning at baseline when they were first recruited into the study, and 20 years later, which is a long time. And what you can see is that across domains, even if there were some gains in vocabulary, which is not completely unexpected, because vocabulary is one thing that actually gets better over time. It's a cognitive domain that gets better as we age. But all of these represent different cognitive tasks and that measure different cognitive domains. And you can see that all of them virtually are worsening as people age. You can see that over 20 years, and this is not, patients entered the cohort when they were in their 20s, right? So these are not like super old people. We're talking about people in their 40s. You can see that there are very large decrements, right? So again, very impactful and does not get better over time. Now, in the clinic, we don't tend to talk too much about it, because I think that we tend to assume that there's not much that we can do about cognitive function, and therefore why you talk about it. But I think it's important because there are things that we can do. There's not a single bullet, clearly, but there are things that we can do to help our patients navigate the cognitive impairment in schizophrenia. The first thing to do is to talk about it. So I think as a clinician, I would recommend my peers to ask patients about their cognitive symptoms. How do you feel about your memory? How do you feel about your attention? Do you feel that you get easily distracted? How do you feel about your speed? Do you feel that you're quick with how you're managing information, or do you feel that you need time? All of these are questions that I think it's important to ask, so that first of all, you patients feel understood, because I think that it's something that they are suffering, but if they are not, no one asks about it, I think that they don't feel that they are being listened to. So I think it's good to be proactive and ask these questions, and then maybe there's something that can be done about it. These are examples of tasks that can be done in patients that have schizophrenia to measure deficits, or rather to measure how patients are doing in a number of cognitive functions. I don't think that you need to memorize this slide, but the learning point from this slide is that you should know that there are different tasks or batteries that patients can do, and they all have trade-offs in terms of how long it takes for the battery to be completed, and all the domains that are being measured. This is something that typically is done by someone that's specialized in neurocognitive testing. And this is part of the team that should be treating patients with schizophrenia, right? So we are typically not working in isolation, because this is a very complex disorder. There are many different domains that are affected, and one person cannot cover everything. Typically, we're going to be working doctors, psychologists, nurse practitioners, psychiatrists, peer specialists, occupational therapists, etc. And one piece of this multidisciplinary team are psychologists or staff that's trained in doing neurocognitive assessments, so that we can then tell patients what are the deficits that they're exploring, if they have some. All right, so now we're going to switch gears slightly, because we're going to talk a little bit about the neurobiology and the mechanisms. And I'm not going to make this very dense. I'm going to make it very, very to the point. And I'm going to talk about two pieces of the biology. The first piece of the biology is the glutamatergic transmission. And the second piece of the biology is how is that glutamatergic transmission modulated by cholinergic drugs. And the reason I'm going to talk about those two is that there are drugs that are already out or under development that interact with all of these elements of the pathophysiology to improve cognition. All right, so let's first get started with the glutamatergic neurons, that transmission. So glutamatergic neurons are the most common in the brain. They are excitatory transmissions. So the glutamatergic transmission is excitatory, and they are very present mostly in the cortex, but also in subcortical areas. Okay. And we believe that the NMDA receptor in particular, which is a glutamatergic receptor, does not function well in patients with schizophrenia. I'm going to tell you what happens in the glutamatergic transmission, and then you'll understand what are the targets of drugs to improve that NMDA receptor, the NMDA transmission. Okay. All right. So you have the presynaptic neuron, and this is happening at large in the cortex and also subcortically. You have the presynaptic input. So the presynaptic input is taking a serine that is being converted to glutamate. Okay. And then glutamate is going to interact with the NMDA receptor. The one that we have discussed is not functioning well in schizophrenia. However, that doesn't do the whole trick, because in addition to glutamate, you also need glycine. So you need the two, glutamate and glycine. Yeah. And glycine is essentially sized by the astrocytes. Yeah. So there's going to be production of the two, of glutamate and glycine. And once the two bind to the receptor, the receptor is going to work. So in terms of the therapeutic drugs that are being developed to address this problem in schizophrenia, they are the direct treatments and the indirect treatments. So the direct treatments, essentially what they're doing is to facilitate the abundance of the glutamate and glycine precursors, okay? So that they're abundant, and that kind of overcomes the limitations of the receptor. And the indirect treatments are things that increase the availability, particularly of glycine. And by doing that, it makes sure that there's enough glycine for the receptor to work. Okay, so that's essentially how it works, how glycine T1, so it's a glycine transporter inhibitors works. It's like an SSRI, but instead of serotonin, for glycine. And that makes sure that there's sufficient glycine in the synaptic cleft for the NMDA receptor to be able to function. And we think that this works because when there's a poor functioning of the glutamatergic transmission, there are what's known as excitatory inhibitory imbalances. So that's what's restored. And I won't go in depth into that. Okay, this is the second piece of the neurobiology that I wanted to mention. And I don't want you to feel overwhelmed at this slide, because I'm not going to go into the full detail. Okay, here I just want to make one point, and that is how can we modulate this faulty glutamatergic transmission in schizophrenia by modulating other neurons, not glutamatergic. So here's how it works. Imagine that you have a sequence of neurons that make a circuit, okay? And this is critical in the pathophysiology of schizophrenia. The first neuron is this one, which is in the cortex. It's going to project to subcortical areas. And then that neuron that projects to subcortical area is going to stimulate other neurons that project within the subcortex to the striatum. And those are the famous dopaminergic neurons. And there's too much dopamine in those neurons. So that's the input into those dopaminergic neurons. And then it loops back to the cortex. Okay, so it's like a loop. All right, so What happens in schizophrenia is that there is too much activity of the neuron that goes from the cortex to the striatum, okay, or to the midbrain, and from the midbrain to the striatum. That's very active. And the reason why we think it's very active is because the NMDA receptor is not working well, and there are loops between this neuron and other interneurons, which make the inhibitory neuron is not working properly either. So then this neuron is disinhibited and there's too much activity downstream. If we modulate the M1 transmission, we may be able to fix how this glutamatergic neuron is working, because now it's increasing the activity of the interneuron that inhibits the pyramidal neuron, and that restores the excitatory inhibitory imbalance I was talking about before, and that's ultimately going to improve cognition. So that's how we think it works. And now, what are the concrete things that are out there, either in development or in the market, that are targeting cognitive symptoms? I'm going to talk about drugs that act at those two levels, at the level directly of the glutamate transmission and at the level of indirectly glutamate transmission by fixing through muscarinic activity. The first drug that I'm going to talk about is iClipertine. So iClipertine is a drug that has been developed and showed efficacy in phase 2 clinical trials. So here, what you can see is the symptom trajectories of people that were randomized to different dosages of iClipertine. So patients were either allocated to placebo or to dosages that went between 2 and 25 milligrams. And there was an effect. There was a dose response, more or less. And the reason I say more or less is that the 10 milligrams separated better from placebo than the 25 milligrams, even if both were effective. So what they saw here is that there was an effect size of 0.3 for the highest dose and 0.34 for the 10 milligram dose. And this was a 12-week trial that showed, again, separation from placebo and good tolerability. As you can see here, the 10 milligrams, which is what is being tested in phase 3, did not show major problems with tolerability. And again, this is, I don't think I said it, but this is the glycine, this is the SSRI for glycine, okay? This is the glycine transporter inhibitor, which is going to increase the amount of glycine in the synaptic cleft so that the glutamatergic transmission works better. So essentially here you see that there are not many differences in terms of tolerability, which is a plus for this drug. So it's now being tested in phase 3. And here what you can see is the design of the study was such so that patients were randomized to the 10 milligram iClipertine or to placebo, and they are being tested in 3 separate trials that have more or less the same design. The primary outcome is being tested at week 26, and then patients are being followed up after the discontinuation of the drug to look at the persistence of cognitive effects of this drug. Here you can see the 2 trials that are being done for phase 3. And we will start getting results in the first quarter. So that's exciting because, again, it's really the first time that we've gotten so far in terms of testing a drug explicitly for cognitive dysfunction in schizophrenia. The other element is really a positive side effect of a drug that was developed to treat psychosis. So this is a normelentrospium, which is available in the market, was approved in September by the FDA for the treatment of schizophrenia. And when they developed the trial in placebo control comparisons, they also measure cognitive symptoms because they were interested, but this was not the primary outcome of the trial. And then what you can see is that there was not an effect for the entire cohort in terms of cognitive symptoms in 5 weeks of treatment of xanomeline compared to placebo. However, when they did a post hoc analysis in which they separated patients with minimal cognitive impairment and those that had most cognitive impairment, what they observed is that actually there was an effect. And those for whom there was a large impairment, those the 50% for whom there was the greatest impairment, actually there was a relatively large effect size in terms of the effect that the drug had on cognition, which is very promising. Here you can see the results from the phase 2 study, in which the drug is fairly well tolerated. The side effects, because this drug is not a dopaminergic drug, what this drug does is to act on the cholinergic interneurons that we were talking about before. So it acts through M1 agonism and M4 positive allosteric modulation. So what it does is that it reduces dopamine synthesis by acting on the modulation of the dopaminergic transmission upstream. But also, in addition to doing that, it seems to be normalizing the glutamatergic transmission and the balance between glutamate and GABA and the excitation and inhibition at the level of the cortex, which could translate into cognitive gain. So that's how it's hypothesized to be working. And then the side effects that you see are related to things like cholinergic or anticholinergic effects. This drug is paired with a peripheral anticholinergic drug because it's difficult to tolerate the peripheral procholinergic effect. So that's why it's a central procholinergic and peripheral procholinergic and anticholinergic that's meant to balance out. But sometimes in patients, we see that they may be exposed to either those pro or anticholinergic side effects. However, the side effects seem to be relatively tolerated and they did not lead to discontinuation of the drug. Then we have Emergent 2 and Emergent 3. So we have phase 3 trials that were identical, that were ultimately led to the approval by the FDA of this drug. So the design is as follows. They randomized patients to either placebo or normal introspium. Patients were for 2 days treated. This is, by the way, a rapid titration. It may have been related to the rate of gastrointestinal side effects that they saw because the titration was relatively rapid and there was a lot of procholinergic and anticholinergic on board rapidly. But they had 2 days of 50-20, 50 of xanomeline, 20 of trospium. Then they increased to 120 up until they completed the first week of treatment. And then they were treated for 4 weeks with the full dose of 125 and 30 milligrams, 125 of xanomeline, 30 milligrams of trospium. And I'm not going to talk about the effects on positive symptoms, which was the primary outcome, but rather on the effects on cognition. And what you can see is that, again, there were some minor gains which were non-significant in terms of cognition in the full sample, but similar to what I showed you before the phase 2, in the phase 3, again, they saw that there was this moderate effect size improving cognition. So this is, again, very encouraging. Here is essentially the same data I presented before. Here, what you can see is how there were cognitive gains across 5 weeks of treatment in those that were most impaired and allocated to xanomeline trospium. In terms of how the drug was tolerated, again, the phase 3 data are not very different from the phase 2 data. The most common side effects were related to nausea, constipation, dyspepsia. So these are things that are result either because there's too much sensitivity to the procholinergic that's on board, or there's too much sensitivity to the anticholinergic that's on board. However, there were no other of the side effects that we typically see with antipsychotics, like weight gain, Parkinsonism, akathisia, etc. And I think it's something important to highlight is that there was not a difference in the rate at which the side effects led to treatment discontinuation, which is encouraging in terms of the tolerability. To conclude some of the information I provided up to this point, cognitive impairment associated with schizophrenia is one of the 3 symptom domains of the syndrome of schizophrenia. It occurs before the diagnosis of schizophrenia, typically occurs before psychosis, is very persistent. It actually worsens over time and is strongly related to functional impairment. Patients want their symptoms addressed, even if it's not talked. We don't talk enough about that. I think it's important that we as prescribers bring it up. I don't think we need to bring up false hope, but I think it's important that we know that there's a problem and then we can do things about it. And again, it's something that persists. Cognitive impairment persists and sometimes actually make it worse when we treat positive symptoms. The reason being that sometimes antipsychotics are highly anticholinergic, which worsens cognition. So that's important to keep in mind to make sure that we are not adding any iatrogenic effects to cognition in addition to what patients have. There are multiple neuroreceptor circuits that are involved in cognitive dysfunction, but most important, it's related to the glutamatergic transmission in the cortex and how the relationship between the excitation that results from glutamate and the inhibition that results from GABA, there's a dance that occurs between the GABAergic inhibition and the glutamatergic excitation. Currently targeted neurotransmitter systems, as I said before, include glutamate, acetylcholine, because acetylcholine is going to modulate that dance between GABA and glutamate excitation inhibition. And again, recognition, screening, and intervention of cognitive impairment associated with schizophrenia is very important, but it remains a big gap in terms of the management of schizophrenia. Second part is the case discussion. So the first case is Adam, who's a 22-year-old Hispanic male. He had his first episode of schizophrenia 9 months ago, okay? So early phase person who recently got the diagnosis. So at that time, he was socially withdrawn, had problems concentrating, felt anxious, grades dropped, and missed a lot of college courses, okay? Classic presentation for early phase in the early phase psychosis. He thought that he was being spied on by hidden cameras. People are at school, and then the streets could read his mind. He also believed that the professors were after him messing up with his brain. And finally, became agitated, and that led to the patient being hospitalized for the first time. Was treated initially with aripiprazole, but had a lot of akathisia, again, very common. And then was switched to risperidone, 3 milligrams, which addressed the positive symptoms. Moved back in with his parents and now has a little interest in meeting prior friends or spending time with his brother, and also does not read the newspaper or the books or any books. So how would you determine whether Adam has any cognitive impairment associated with schizophrenia? So we have perform a mini mental, ask the patient, ask the family of the patient about activities, difficulties, and ask the patient. Of those, I think that certainly the place to start is to ask either the patient or the family. You know, that's, as we said before, that's the place to start so that's where I would start the conversation. I don't think that in and of itself is going to be confirming anything, but probably it's more running a battery. The question is whether that's accessible to you, but certainly that's what I would recommend to confirm. But yes, I think I would start the conversation by asking the patient and the family member. So these are some of the domains of cognition that are impaired. As we were saying before, there's attention, which is very typically affected in patients with schizophrenia. So what the definition of attention is the ability to sustain attention to one thing and ignoring other things, right? So stay on the signal, ignore the noise, right? So how does it look? How does it show? So patient's going to say, I cannot read a book, I cannot pay attention to a movie. That's a classic present clinical manifestation of this. Then working memory is another symptom, is another cognitive domain, and that's the ability to retain information in our mind so that we can manipulate it and to do something about it. This is something that this is a classic impairment in schizophrenia. This is very common, and there are large impairments in terms of the effect size of working memory in schizophrenia. And a very easy way of measuring it is to know if the patient is able to retain a phone number. You know, so can you read the phone number, retain it for a few seconds, and then dial it? That's an example of something that will be impaired, that will not be possible due to working memory deficits. Verbal learning and memory. So that is the ability to retain, but maybe for longer periods of time, a list of items. So for example, to be able to retain the memory of what do I need to buy from the supermarket if I'm going to buy whatever. Visual learning and memory is similar to that, is where did I leave my keys? Reasoning and problem solving, that's a little bit different. And that's the ability to apply strategies and to manipulate information in a logical sequence and then to reach to a conclusion. So that's manifested by the ability, for example, of the patient to get on the bus and go from one bus stop to another. And then if something changes, maybe I had an appointment at 10, was moved to 10, is the patient flexible so that they can adjust their plan? Speed of processing is something that also tends to be impaired in schizophrenia, so that you can see very easily, ask the patient to do a task and see how long it takes for them to perform the manipulation of information. And social cognition is something that's very important and a bit more difficult to measure, but the most relevant is the ability to attribute mental states to other people, or to recognize, for instance, to recognize if someone is angry at them, if there's no verbal cues. That's another example, something that would be impaired in patients with schizophrenia. And then those are things that are clinical manifestations. But to confirm, you should a formal cognitive test, and there are a number of tests that are recommended. They have different trade-offs in terms of how long they take and how much information you get from them. And this is something that is usually administered by people that are trained in the administration and interpretation of them. So the way it works is that you will essentially, if you're working in a multidisciplinary team, you're going to get a readout about what are the domains that are impaired according to whatever battery that they decide to run. Okay, so let's continue with the case. Adam does not read the newspaper or books anymore. Okay, he used to do that when he was in college, but now he cannot concentrate. Okay, so he gets lost when he is reading. He gets lost in the page. See, now he also watches brief movie clips, but he cannot follow the plot. I mean, I don't think that this is being helped by the all of the examples of like short clips that you see on social media and things like that do not require you to maintain attention. I think that in general, the population has worse performance in being able to sustain attention for longer periods of time, not only patients with schizophrenia, but certainly in patients with schizophrenia, we see that. Yeah, so they will say, I cannot follow a 2-hour movie. He did spend time with his younger brother previously. He would hang out, going for a run, but now he doesn't want to be bothered. So there's little motivation. He may not be able to sustain the representation of reward that's associated with spending time with his brother. He uses marijuana intermittently to chill, but doesn't have a comorbid substance use. He also states that he's gained 18 pounds and often feels like he has brain fog, which he really doesn't like. So you see that some of these are things that patients do not enjoy. And then upon examination, you detect that the patient has reduced arm swing when walking and some elbow stiffness. So this should make you think of secondary negative symptoms. We can talk more about that, right? But if you see someone that is stiff, they may actually be presenting with negative symptoms that are not caused by the illness itself, but the antipsychotic. If you're not able to move your face muscles properly because you're feeling stiff, that's going to look like as if you had negatives. So what treatment changes would you discuss with Adam based on what we showed you? So people said decrease the dose of risperidone to 2 milligrams. And I suspect that this was motivated by what we were discussing before, right? That the secondary negative symptoms, which could be caused by the Parkinsonian side effects, which are dose dependent and are very common with the use of risperidone, right? So you could maybe decrease those secondary negative symptoms. Typically, even if they are dose sensitive, you're going to be playing a very dangerous dance between going up on the dose so that the patient is protected against relapses, but then going low so that you don't have that side effect. So that's a good idea, but so that's dangerous. And okay, so someone else was saying change to olanzapine or quetiapine. That makes sense from the perspective of motor side effects, but not from the perspective of the anticholinergic burden. Those are drugs that are very anticholinergic and are not going to help with all of the other cognitive symptoms that the patient is presenting with. Switch to KarXT would make sense because that, as we discussed, may have some benefits in terms of the cognitive function. And switch to lumateperone, lurasidone, or cariprazine are also options that would make sense because they are well tolerated, don't have so many motor side effects. But if KarXT is available, I think that KarXT has data for cognition that's not present with the other options. Okay. So whenever you see someone in the clinic with all of these presentations that we were discussing, the lack of social engagement, the inability to follow commands, or lack of flexibility, adapting to plans, slow processing of information, forgetting things, all of this are going to be part of differential between cognitive symptoms and negative symptoms. And there are multiple contributors to this. You're going to have to consider a lot of different things. You're going to have to consider whether this is caused by EPS. Is this caused by sedation, which are side effects of medications? Is this caused because of chronic pain or because of sleep apnea, which is also very common in schizophrenia? Many patients have sleep apnea, which could present with cognitive symptoms. Is this related to environmental deprivation? If you're not interacting with other human beings, then you're not going to that's going to have an effect on your on your social skills. And then there are other things that are primarily related to the illness, which could be the hallucinations, substance use, depression, anxiety, even dementia, which is more for which patients with schizophrenia are at greater risk. All of this will go into the differential that you'll have to run whenever someone presents with the symptoms. Metabolic syndrome, we didn't talk too much about it, but it seems to be associated as well with all of these problems that we described of cognitive symptoms. And then, so the next steps about Adam, the clinician still wasn't familiar with KarXT and then proposed to change to lurasidone. Positive symptoms remain unchanged, motor symptoms improved, and he spends time again with his brother, has a little bit of a better cognition, is able to watch short movie clips, going for a walk with the dog, but still is not able to watch a full movie. So you see that there's been a little bit of an improvement for any symptoms that were secondary were secondary, but is not fully addressing the problem. So now at this stage, you have switched to lurasidone. We're helping a little bit, but not entirely. What would you do at this point? Cognitive behavioral therapy or cognitive remediation is not unreasonable and is not incompatible with switching to KarXT. From the perspective of the drug management, I would switch to KarXT, but I agree with those that answered about that were answering cognitive remediation, because that certainly would be indicated in patients with cognitive impairment associated with schizophrenia. So to wrap up, we'll just cover the recommendations of the APA for cognitive impairment associated with schizophrenia. So there's a recommendation for the assessment, and there's a recommendation for psychosocial intervention. And for the assessment, it's recommended that patients are asked clinically, but also that they do a cognitive assessment, particularly important in the early phase of the treatment so that we can plan the interventions accordingly. And the recommendation by the APA is not for any drugs yet, but they are recommending psychosocial intervention. So as we were saying before, they are recommending CBT for psychosis and also cognitive remediation. Those haven't shown efficacy for cognitive impairment in schizophrenia. So that leads to the conclusion of the program. Thank you very much for your attention.